There you go.
So when I'm drawing it out myself, I have your kind of diagram from the course manual here. I'm just gonna.
Which one? The line drawing?
Well, I kind of drew lines on it. This one.
Oh, okay. Yeah, all right. Okay, yeah, you need lines on that.
Yeah, so it was a little confusing.
That's why I do you these perfect diagrams, and you.
I know,
right?
right? Well, I did take a picture, but it kind of looked like my diagram here, so that's why.
What do you want to know?
Okay, so after the anterior inferior cerebellar artery,
Yeah.
it's the labyrinth internal auditory branch.
I have no idea about the order of them, and I'm not worried about it. The the ones that are on that part are the Pontine Arteries.
And that's off the basilar, right?
Yeah.
Okay.
And the acre and the internal auditory, and they're really the only ones I'm worried about.
Okay. So is the Pontine artery, is it off of the anterior inferior cerebellar artery?
No, they all come off they come straight off the basilar.
Oh, okay. That's where I'm going.
So they come off the basilar and wind around the pons and the medulla. So they supply the pons and the medulla, actually.
Okay. Okay. And then is the, so, and then the other one I was confused about, this superior cerebellar artery, that's above that, above the basilar?
No, that's a posterior cerebellar. Posterior, hang on. The posterior cerebral artery.
Yeah. Okay. So the superior cerebellar.
The basilar, actually, the superior, we haven't got a superior cerebellar one there.
Okay.
There's a pica and the acre. Hi, James.
Okay. Okay. And then the off of the posterior cerebellar artery, there's the cortical, the thalamic, the calcitrine, and the temporal.
It's the posterior cerebral.
Okay. Yeah.
Okay. Then, yeah, it gives off the central or thalamic artery and the cortical artery. So it bifurcates there. Then the cortical bifurcates again.
Okay.
Into the calcarine and temporal arteries.
Okay. Calcarine. Okay. Perfect. Thank you.
Okay. Is that it?
Okay. Yeah, and then off of the MCA is the thalamic and the central?
No, off the middle cerebral artery is the anterior cerebral artery.
Okay, yeah, okay.
And the posterior and the anterior communicate artery runs between the two anterior cerebral arteries.
Okay. So there's nothing that branches off of the
It does loads of stuff. The middle cerebral does loads of stuff, but I'm only interested in that part of it.
Okay. Okay.
So the middle cerebral does the entire brain except for the bit that the vertebral doesn't.
Right. Okay. Okay. That makes it a lot clearer for me. Thank you.
And it's not kind of a diagram. It is a diagram. Evening, James. You're on your phone, you can't answer. All right. Okay. So, bunch of questions here. I'm going to put the questions on the screen. So let's do this. I can figure out where the hell it is. Oh God, I hate these things. It never does what it's supposed to do. There it is. That's not. There it is. Okay. Okay, most of these were from you, James. So no particular order except what I wrote them down in. Question 9. Match a condition in column 1 with the most likely signs and symptoms in column 2. Okay, so we're missing a few there. Oh no, actually it's down below it. Okay. All right, so this wasn't one of yours, was it, James? So I'm not sure what the problem is here. Can you do it? Kim, James, can you do this one?
Yeah, I think I can. So I put primary bone cancer would be C, the full range of motion.
Yeah.
Lumbar disc herniation would be B, leg pain worse than back pain.
Yeah.
Acute SI joint arthritis, I put A, sharp pain and turning in bed.
Yeah.
Mechanical low back pain, I put D, which was the episodic pain.
Yeah.
And the isthmic spondylolisthesis, I put E, which was the bilateral leg pain.
Yeah. I'm not sure why anybody was having trouble with that. Yeah, that's good. Okay. Question 10. I think there's just too many things. These are not easy, these questions, if you don't know them. Match the brain region in column 2 with the external symptom in column 1. So dysphagia is low down, it's medulla.
Okay.
Dysphasia is actually Wernicke's area. So it's going to be the temporal lobe. Vertigo is going to be the vestibular system, so it's going to be pons. Ataxia will be the cerebellum, and hemianopia will be the occipital lobe.
Okay, so vertigo was the pons. Okay, that I got those two mixed up, pons and the cerebrum. Okay.
Yeah, the cerebellum's a higher level than the brainstem is. It's a higher order brain, so it tends to be involved more in higher level functions and coordinations. It does a lot of balance stuff, muscle tone stuff, and so on. It's a lot more complex than the midbrain, and not as vital.
When you have questions like this, Jim, where you're matching a few,
yeah,
is it all or nothing?
It was. I've changed it a bit now.
Okay.
A bit nicer to you. So you're not getting a point for each correct answer, but you're getting a total of 3 points.
Okay.
But yeah, that was all or nothing.
Okay.
I'm fed up with the whining, so I gave it to 16. Which of the following is true about craniovertebral instability? There are usually spinal cord signs and symptoms involved. It's frequently caused by severe trauma. It's most commonly associated with systemic arthritic disease. It's commonly seen in general practice. Well,
I put it as frequently caused by severe trauma.
no, that's rarely the case. Very rarely the case. It'll fracture the dens before it tears the ligament. So you end up with an instability there, but it's a fracture instability.
Okay.
Which is not quite what we mean. So it's usually caused by systemic arthritis.
That was my next guess.
Yeah. Because generally speaking, if this is caused by severe trauma, the patient generally doesn't survive it.
Okay.
List the classification type of dizziness in column 1 with a description in column 2. We did this one before. No, that's because it's not on there. Sorry, I'm going straight down the list. We had some problems with that, and I'll just go over it again. The problem was vertigo. So vertigo can't be vertigo. All right, you can't have vertigo and vertigo. Vertigo is a question, and vertigo is the answer. So the description of vertigo is it's a spinning movement. Yeah. The rest of these should be fairly straightforward. That's the one that caught somebody out. You good with that?
Yep, I think so.
Okay, so that was the last one we did. I was up here. 16. 25. Match the signs and symptoms in column 1 with the area of compromise in column 2. Okay, well, it's a fairly straightforward anatomy question.
Okay. Oh, sorry. Getting lots of feedback here. So bilateral upper limb paresthesia.
Mm-hmm.
I actually struggled with this question as well.
Okay.
So bilateral upper limb paresthesia, I put spinal cord.
Yeah.
Okay.
I
And
mean,
then,
if it was on there, it could be lateral stenosis, central stenosis, but it's not on there.
right.
It's not one of your choices.
Okay.
Yeah.
So then hemilateral paresthesia, I put brainstem.
Yeah.
Unilateral upper limb paresthesia, I put lateral spinal stenosis. Is that right? Okay.
Yeah. Yeah.
Radicular pain, I put nerve root.
Yeah.
And non-segmental causalgia was the peripheral nerve.
Yeah.
Okay.
The only ones there that might be confusing is A and E. And basically that's because you rarely get radicular pain with lateral stenosis.
Right.
And that's usually the predominant symptom with lateral stenosis is usually paresthesia.
Okay.
All right. And this is all about best fit, not perfect fit. 25, 40. These are yours, James, I think. Which one of the following statements is true regarding the incidence of vertebral artery injury from cervical manipulation? Okay, that's fair enough. It is extremely high and in-depth discussions with the patient are necessary before treating. It is so low that the risk need not be discussed with the patient. It's a minor risk that should be discussed with the patient. There are no good studies available to determine the risk, so no discussion is needed with the patient. We actually talked about this one the week before, I think. And basically I was caught out for being hypocritical. So what's the answer?
I said minor risk that should be discussed with the patient.
Yeah. Yeah. The fact that I don't discuss it with them is neither here nor there. That's me. And if I was answering this as a quiz, I would give the answer C as well, even though I don't do it. But then I've got no ethics whatsoever. That was 40. 42. On testing hearing, increased sensation of humming in the deaf ear is indicative of sensory neural deafness. True or false?
True.
No, it's false.
Okay.
Block one ear.
Okay.
Now hum. Where'd you hear it?
Over here.
You hear it in the other ear?
Yeah, I don't have great hearing though.
Really? Block that one. Do it again. But
block what? White good ear?
Yeah. No, block the left ear. Hum there.
Yeah, I hear that. I hear
You've got
it
a
in this
hearing
one.
problem.
I do.
Have a hearing problem there. Yeah, it tends to enhance bone conduction. Conduction deafness does. Sensory neural deafness, you're deaf. It doesn't matter how the sound gets there, you're deaf to it.
Okay.
So essentially, if you test the ears first for air conduction, you establish which one is the deafer of the two. Then you plug both ears, hum, and if they hear it in the deaf ear that you've already established, that is conduction deafness. If they hear it in the good ear and not in the deaf ear, that's sensory neural.
So if you hear it with the ear plugged, if you hear it in the good ear, that's sensory neural?
No.
No.
Well, okay, let's say that you've tested hearing with air conduction, the right ear's deaf.
Okay.
You plug both ears, hum. If you hear it in the deaf ear, that's air conduction deafness.
Okay.
If you hear it in the good ear, that's sensory neural deafness. James, I'm assuming your mic's not working with this. and this is really your question, so I'm not sure if we're doing okay or not with you. Do you have non-verbal reactions on your phone, James? If you do, just do a thumbs up if you're okay with that question. If you can't communicate with me, email me afterwards, all right? If you've got any problems with the answers. So that was 42, 46. There we go. Hello, Tolu. Hi, Tolu.
Hi, Jim.
How are you doing?
Good, and you?
Good, thank you, good. So 46. The client's test has been demonstrated to be very sensitive for VBI, true or false?
True.
The problem is it's very debatable one way or another. I've actually changed that question to specific because of this. So if your positive is dizziness, then it probably is very sensitive for VBI. The trouble is it's really not sensitive for VBI, it's sensitive for anything that produces dizziness. So it's sensitive for all sorts of things. One thing it's not is specific. Unless we're using neurological signs and symptoms when it does become specific, but not very sensitive. Does that make sense?
So it's not specific. So if you get dizzy, it may not potentially.
Yeah, if you think about it, if I've got a vertebrobasilar problem.
Yeah.
Okay, forget the vertebral artery. Let's say I've got a labyrinthine problem.
Okay.
Okay. And I put them in that declined test position.
Yeah, they're going to get dizzy.
Yeah. And if I've got proprioceptive problems in the neck, then they may well get dizzy then as well. So the test is sensitive for anything in the head or neck that might produce dizziness. The thing is, though, that dizziness isn't very specific for VBI. So the test is probably quite sensitive for VBI, but not very specific.
Right. Okay.
Okay. So I'm going to change that question anyway.
Okay.
Tolu, when you answered that one on the test, oh, you haven't done it yet, have you? Of course not. You haven't done it. Sorry.
No, not yet.
Does that make sense to you, Tolu?
Yeah, it does.
Okay. So that was all the questions. Let's go through a few more of these because we've only been doing it for 20 minutes and see what you come up with. Okay, the next one down, facial paresthesia should be considered evidence of which one of the following: trigeminal neuralgia, facial nerve compromise, trigeminal segmental facilitation, midbrain ischemia.
I said trigeminal neuralgia.
Same with me.
Why?
Because of the paresthesia.
Okay, now, if you read the question, which one should be considered evidence? Which one of the following should be considered of? So what's the worst case scenario there?
The worst case?
Yeah.
Would be midbrain ischemia.
Midbrain ischemia.
Yeah. So it's probably not a bad idea to pick that one.
Oh.
All right. It's not about making the right diagnosis. You can't, not from this. You haven't got enough information to make that diagnosis. It's not about making the right diagnosis. It's about making the smart one. So it needs investigation. So you assume it's midbrain ischemia and get it the hell out of your clinic.
Okay.
Tolu, does that make sense to you?
Trying to reason it out.
Okay, you're treating it as an academic exercise. All right, both of you. But this is a practical test. I know it's written, but it's still practical. So of all those four things, the one thing that you're going to bugger the patient up with is midbrain ischemia. You can't do any more damage to trigeminal neuralgia. Same with facial nerve compromise. Segmental facilitation you can do something about. But midbrain ischemia, you're running the risk of doing some serious damage to them. So that's the one you go for, because it needs more investigation. Otherwise, what I'm going to do is ignore it, say, okay, we've got a neck problem. I can't make the trigeminal neuralgia worse. I can't make the facial nerve compromised nerves. You need to go and have these sorted out by your doctor. The trigeminal facilitation I can treat, and I'll do that by manipulating your neck. So if those three are wrong, you're left with midbrain ischemia, then you can damage. Yeah. So you pick the least worst of them in these circumstances. Tolu, does that make sense?
Yeah, it does.
Okay. Patient with cervical rib who requires craniovertebral manipulation is a safe candidate, providing the lower cervical spine is protected from the force of the manipulation. True or false?
False.
False.
Why?
Because that's an anomaly and they could potentially have.
Yeah. They can potentially have the vertebral artery anomalous as well. In fact, there's a good chance they do. Probably the anomaly in the vertebral artery is not going to be damaging, but you don't know that. Tolu, have you got any of those questions you want to ask me on this? Anything that's stumping you?
I think the ones I'm still struggling with are those ones that you match, the matching ones, like 41, 10.
Okay. What numbers have you got? Sorry.
41.
31.
41.
41. Okay, massive test. This is, again, this is about anatomy. Yeah. So if you look at the first one, you can actually eliminate some of these as well. You know what the decline test tests, yeah? You know what Hallpike-Dix tests there. So the rest of these are a bit, you have to think about. So we did the confrontation test in the cranial nerve exam, yeah? So the answer there is going to be actually it's not midbrain. It's a visual test, so it's going to be the occipital lobe. Yeah, Tolu?
Yeah.
Okay, Hallpike-Dix.
Vestibular.
Vestibular labyrinth.
Yeah. Decline.
Vertebral artery.
Yeah. Jaw jerk.
Midbrain. Midbrain? Sorry.
Yeah, it's the trigeminal, isn't it? It's the muscles of mastication. It's the trigeminal nerve. So midbrain, and then Hoffman, the spinal cord. What was the source of confusion with that one for you, Tolu?
To the confrontation. That was when I got a little bit confused.
Okay, well, it's a visual test. Yeah, you're looking at their visual fields.
Yeah.
So this is either in the midbrain with the lateral geniculate nucleus, but more usually it's an occipital lobe problem, or possibly the calcine radiation. But the only one you've got in there that fits is the occipital lobe.
Yeah.
Yeah.
Thanks.
You got another number there? to find one myself. All right, number 25, which we did. Is that an issue, Tolu?
25. Did you already talk about 25?
Yeah, but what's your problem with it?
I don't think I have any problem with this one. I'm just trying to see if there was anyone I. Hmm,
17?
17. Okay, I think the last time we were talking about 17, and then I think most of us that were online that day were a little bit confused because you had dizziness listed on both sides, and
No,
then
I had vertigo on both sides.
I mean vertigo rather.
Yeah,
And
but if you
then
look at this, list the classification type of column in column 1 with the description in column 2. So vertigo is a description of this, is a type of dizziness, type 1 dizziness, and it's a subtype of type 1. So it is a type of dizziness. So you can't describe vertigo by saying they've got vertigo.
yeah,
So the answer is spinning.
spinning. Yeah. Okay, and then vertigo type 1 will match vertigo on the other side. Yeah, I think that makes sense.
Yeah, exactly.
That makes sense.
You good?
Yep.
What about number 10?
But
You okay with them or not?
just give me a minute. Get you while
Let's work through this as if I don't know a couple of these, all right? So I don't know where dysphagia is, all right? I have no idea where that comes from. Now, if I don't know a couple of them, we're going to get in trouble. But let's assume I know the other ones, all right? Then I can easily match these up. Hemianopia will be the occipital lobe, ataxia is the cerebellum, vertigo is the pons, and dysphagia is the temporal lobe. So it only leaves the medulla for dysphagia. So you can eliminate stuff from what you know. If you don't know a couple of them, you're a bit in trouble. For example, if I don't know where vertigo is or where dysphagia is, then I'm going to have trouble matching this up. So you need to know at least 5 of them, 4 of them, 4 of them. What about number 6? Which of the following is an absolute contraindication of manipulation? A postmenopausal patient, an immediate onset of torticollis after trauma, history of trauma, history of severe delayed post-traumatic pain.
I think we answered that already. An immediate onset of acute torticollis after trauma.
Yeah. Okay, the rest of these are fairly straightforward. You see a lot of postmenopausal women.
Yeah.
The history of trauma is common, and usually that pain is fairly severe. But post-traumatic severe pain is generally inflammatory.
Yeah.
Yeah. Hi, James.
Hey, Jim.
Which, you got the answers, didn't you, when you was on the iPhone, yeah?
Yeah, I could hear. There's a few that I might get you to go back to.
Sure.
But yeah, for the most part, I did hear what you were going through.
Okay, which ones?
Oh, good question. Hold on. Hold on. I gotta pull it up. I think the one on declines, about, I forget if it was sensitivity or specificity.
Oh yeah.
I kind of missed that one.
Okay. The declines test is going to be extremely sensitive for anything that causes dizziness. All right, because that's what it's picking up. If dizziness is your go-to symptom for a positive decline test, then anything that causes dizziness is going to show up positive. So it's quite sensitive for anything that causes dizziness that is related to head and neck. Yeah. So in that respect, it is quite specific. The problem is there's no evidence, good research evidence for this, because nobody does studies on people with known vertebral artery problems. So it's a bit of an iffy question. I'm going to change it. And I'm going to change it from sensitivity to specificity if I leave it in. Because like the test as it stands, that is looking for dizziness. In fact, I'm going to have to rewrite that question. If your positive is dizziness, then it's very, very much non-specific for VBI. Okay. If your positive, so are neurological signs and symptoms, then it's very specific for VBI and not very sensitive for it. Is that okay?
Yeah.
But I'm not even sure that's true. It might be very sensitive for VBI. Or this is the problem with it. It's such a rare condition. My guess is that VBI patients will end up being positive for the most part if you do decline. Okay. If you use neurological signs or symptoms as your positive for VBI, then it's probably very sensitive and very specific. But it won't be sensitive for other causes of dizziness under those circumstances. Not if your positive is neurological signs and symptoms. I'm going to do something with that question. I may simply take it out, or I'm going to have to reword it because it's a problem. If I reword it, it'll be an easier question to answer. Okay, fair enough. You got that one a bit confusing. That's fine. Anything else? These are quite interesting. I was looking at these today. Patient presentation includes minimal loss of range, moderate right low back pain, referral to the right bucket, right trunk deviation on extension. All else being negative, this patient is a candidate for manipulation. True or false?
I said false.
Why?
Because of the minimal loss of range.
There can be. The amount of range loss is determined by the amount of pain you're suffering in almost every instance. Tolu, what do you think?
False.
Why?
Because the severity of the pain doesn't match the minimal loss of range.
Well, it's only moderate pain.
Did you read question 38 or 39?
We're looking at 36 at the moment.
36. Minimal.
The thing is, you're not likely to see this patient come into your clinic because he's not having too much in the way of back pain. But if they do, this is a godsend. This is easy to treat. Manipulate it, they go away happy. It's just it doesn't come in very often because most people can ignore that degree of pain. Unless they're an athlete. Then they're big babies and everything hurts. And it's not perfect. That's what they want, is perfection. That's why I hate treating these people. 37, moderate loss of range, moderate right low back pain, referral to the right buttock, right trunk deviation on flexion. Candidate for manipulation?
Yes.
Yeah, the only difference there is getting deviation on flexion rather than extension. Yeah. It's the one you didn't have any trouble with, Tolu. Minimal loss of range, severe right low back pain, referral to the right buttock, right trunk deviation and extension. And you're quite right. He should be getting a lot more loss of range than he should.
I think that's the one I thought you read earlier. So that should be false.
Yeah. Yeah. 39, moderate loss of range, moderate right mid-cervical pain, referral to the right trapezius, left-sided headache. Manipulation candidate or not?
False.
Why?
The left-sided headache. I think
It's
that's
on the wrong side for everything else, so it's not likely to be referred. In fact, you pretty much bet your house it's not going to be referred. So there's something else causing the headache.
Did you already talk about 18?
18. Not today. Okay, which one of the following is usually the cause of the most severe vertigo? Cerebellar disease, head injury, vertebral-basilar ischemia, labyrinthine pathology.
Labyrinthine pathology.
That's one answer. Two answers. Tolu?
Most severe.
What are you thinking?
Well, I was thinking vertebral-basilar ischemia.
Okay, I think you're looking at what is the most severe pathology that can cause vertigo.
Okay.
Okay, this is about the severity of the vertigo, not the severity of the disease.
Okay.
So if you've ever seen anybody with Meniere's, you know damn well it's labyrinthine pathology. These people can't even move their eyes without spinning and throwing up. So don't get confused by the question. It's not the most severe pathology, which I would agree with you, is vertebral-basilar ischemia from our perspective anyway. It's the most severe vertigo.
Okay.
Is that okay?
Yep.
Okay. There was one here that I was looking at earlier. One here about a 14-year-old girl somewhere. I might have been looking at different tests. Okay, I can't see it on here. Huh. He's gone. Let's see if I can remember what it was. This is a 14-year-old girl, soccer player with right low back pain of gradual onset. What's the most likely diagnosis here? What do you think? We're talking about an onset to peak of about a month or 6 weeks, somewhere in there, gradually worsening over that period. What's your best hypothesis? Nothing? All right, what conditions get gradually worse and worse and worse? Any condition you like, just give me some conditions that get worse and worse and worse.
Fracture,
What sort of fracture?
like stress.
Stress fractures, tumors do, but in this case, it's probably a stress fracture. Like subluxations don't do that. They hurt or they don't hurt, and they reach peak fairly quickly. It's not an obvious fracture. It's not an overt healthy tissue fracture because that's sudden onset as well. So it's gradual onset. You've either got some form of weird arthritis, a tumor, which is very unlikely in a 14-year-old girl, especially down there, or it's a stress fracture. She's playing soccer, and that involves a lot of talk with her foot planted. So this is a profession that actually does get stress fractures here, especially in girls. So one of the questions you can ask her is, how's her periods doing? If her periods have stopped, that basically enhances your suspicion. Yeah.
Can we talk about 13 again, Jim?
13, Down syndrome that causes Orlando instability in adults more commonly than in children. Okay, there was an article that came out looking at this with flexion extension x-rays quite a while back now, and they found that Down syndrome children were no more unstable than normal children. Down syndrome adults, on the other hand, were. And I suppose the argument is that they haven't had time to degenerate. So there's plenty in there that's going to stabilize it until the joints degenerate as well. And then when they start to degenerate, then they get into trouble. But instability is much more common in adults than children with Downs. It's a bit of an academic exercise though, because probably you don't want to manipulate Downs patients of any age. Also, it's best to understand that kids under 12 don't have a bony dens anyway. And this is probably where they're looking at it. Like, they're not unstable. Kids have a cartilaginous dens that gradually ossifies, but they're not unstable. They're vulnerable. This is one of the things they're saying, that these kids should not be playing American football because of this. But they're vulnerable, but they're not unstable. And that's probably the comparison between two groups, non-Downs children and Downs children. But yeah, they don't have a bony dens until about 12. that okay?
Yep.
All righty. I think we've pretty much exhausted all these now, haven't we? I believe we have. Okay. If there's anything there you want to talk about next time, then fine, let me know and we'll discuss it. Otherwise, I think we're pretty much done. But I'm quite happy to revisit it. So I'll come up with a different topic for next week. Is there anything you want to discuss now? We've got 15 minutes or so left. Or do you want to get back to your reruns of, I don't know, Big Bang Theory?
Jim, I know a few people who have taken your course, and when we applied to the college to get on the roster, a few of them thought they remember that maybe in your manual or whatever, there was something that pretty much they were just able to copy and paste and put into that thing for the college.
Okay, I'm not sure what they want there now, but have you seen the form?
I have not looked at the spinal manip one. I've done one for needling.
Okay, I'll tell you what, see if you can find it. I'll see if I can find it. And
Okay.
if it requires something in writing, because it used to be I just gave you took the certificate and showed them that. But if it requires something in writing, I'll do it.
Because I know for the needling, they wanted to know like how you were examined and all of that stuff. Yeah, but I don't know about the manipulation one. I don't know if it's the same form.
I don't know, they've changed things recently as well.
Okay.
So.
Okay. Yeah.
All right, see if you can find it. Let me have it. If you got it, I'll see if I can find it, and
Okay.
I'll go from there. Okay.
Yeah.
It shouldn't be that much of a problem. And I did do that before. I remember doing that before, but I don't remember exactly what it was.
Okay.
Do you know they could get away with all this if they were simply to require you to do this type of course in cervical manipulation? All of this stuff would be done. You wouldn't have to worry. You could manipulate everything else, but manipulating the cervical spine would be a restricted act, which is really all it comes down to.
Mm-hmm.
You know, but they're like everybody else. Just let's make sure that we're really covered. You can't do anything. You know, I really have to worry about them sometimes. I just heard a story about a guy who was a PT who had a complaint lodged against him. And it was basically, he didn't do anything wrong, did the right treatment, but this was a 40-year-old man with his mother in tow. All right, so she's hovering over all this. And she said that he didn't give him enough electrical treatment, and that was her complaint. And the college is actually investigating it. Now, if you can't make your own treatments up, and it's dependent on the patient's whim, what they like and what they don't like, we're all in deep shit. And I blame the college for this. It's really a stupid thing to do. Absolutely stupid. The patients have got no qualifications to tell us how to plan and carry out treatment. None at all. But this is what colleges do.
Sorry, Jim, I might bug you on one more question. 31, did you go through 31 at all? And I missed it.
No, it wasn't one of the ones you gave me. So let's see if I can get it.
Yeah.
31. I think we covered this a couple of weeks ago. Which of the following would make you most suspicious? That's fine. Most suspicious of severe pathology: post-traumatic pulsating tinnitus, severe neck pain, severe headache, extensive referred pain. So what do you want to answer?
Post-traumatic pulsating tinnitus, maybe, but I'm torn also maybe between the extensive referred pain.
Well, that could be a disc herniation.
Right.
Or it may just be severe pain referring a lot.
Right.
And neither of those are necessarily life-threatening. But pulsating tinnitus is you're hearing your own heartbeat.
Mm.
And generally speaking, it's bruit that you're hearing. So there's been damage to either the carotid artery or the vertebral artery.
Okay.
Now, people get this anyway. If you're in a really quiet room, no ambient noise, a lot of people can hear their own heartbeat. But post-traumatically, where it's never been present before, would suggest a vascular injury. Is that okay?
Yeah, makes sense.
All right.
Perfect. Thank you.
Jim, just one more thing. Can we go through question 9 just before you go?
9. Match the condition in column 1 with the most likely sign and symptom in column 2. Okay, it's a matter of pathology, isn't it? So let's look at the first one, primary bone cancer. So what do you think? Tolu? We did this one earlier, but carry on.
Oh,
that's all right. Primary bone cancer, which one? If you're not sure, leave it for the moment, all right?
Okay.
See what you're left with. Lumbar disc herniation.
Okay, I would say leg pain worse than back pain, but
yep, that's good.
Okay, and then acute SIJ arthritis.
Yep.
Sharp pain turning in bed.
Yeah, it's the only one actually that makes sense of any of them, isn't it? Even if you don't know that, it's not episodic because it's an arthritis. It's not bilateral. And you've already used up full range of motion, so you're only left with that one. Mechanical low back pain.
Episodic pain.
Yep. And isthmic spondylolisthesis.
Range.
Range. Well, you've seen a spondylolisthetic patient, haven't you? What's their major complaint?
Pain.
Where do they feel the pain?
On the back, an extension.
Yeah, but where else? Now, we're talking about an isthmic. This is not degenerative. This is now a deficit in the isthmus. So this is usually in kids, like under 20s often. Even degeneration. They get bilateral pain, don't they? Bilateral back pain. They get bilateral leg pain. Because you're pulling on all the dura and the nerve roots when it slides forward. If you're seeing it unilaterally, then it's probably not spondylolisthesis that's causing the problem. Is that contrary to what you understand, Tolu?
No, it's not.
Okay, then it only leaves you one for the primary bone cancer. Full range of motion. So you can work your way through these, even if you don't know them, you can work your way through them.
Yeah. Yeah, that's fine. Thank you.
You okay with that?
Yes, I am. Thanks.
All righty, good. Okay, anything else there? All right. I think what I'll do is I'll send you out some, I don't know what I've sent you in the form of essential illness scripts, but I've got some videos, short videos on them. And I've got them for the lumbar spine, I've got them for the cervical spine, so I'll send those out to you
right.
next week, and you can look at them.
Okay.
All right. Because I'm going to put some more EIS questions on there. All right. Okay, guys. Good.
Thanks, James.
Yeah, thank you.
Yeah, if
Thanks,
you've
Jim.
got any more questions on there, we can do them. I'm not running away from it again, but we'll revisit it. But I think we'd probably do better now talking about other stuff. Okay. All right. Good night, everybody. Have a good one.
Thanks.
Thanks, Jim.
Take care. Bye.